This is postprandial time, so I'll start with kick off with. So this talk, I'll try to finish in half an hour's time, but they start with MCQs, a bit of one clinical case, the issues from the clinical case, and how to manage the clinical problems. That's the main theme of the day. As this is postprandial period, I'll start to ask you these things. So which of the following is not the core features of Parkinson's disease? Postural instability, rest tremor, rigidity, bradykinesia, apathy. Just shout out quickly. Or if you want to write it down, then you can do that. Anyone?
Can you see the chat box, Anil?
Rest tremor is just one answer.
Yeah.
I think so. I think it's important that I just tell you the core features of Parkinson's is tremor, rigidity, bradykinesia, and rest tremor is important, and postural instability is there. Apathy is not the part. So the way Parkinson's is described as rigidity, bradykinesia, rest tremor, and about 2 decades ago they put it postural instability as well. So apathy is part of it, but that is not the core feature of Parkinson's disease. Okay. Now, you're in the clinic. Which of the following is incorrect about essential tremor? Asymmetrical, may improve with alcohol, may respond to propranolol, may run in family, and that scan, that dopamine activate transporter scan will be negative. What do you think? Shout out, write down. Anything?
Asymmetry.
Sorry, asymmetry. Yeah, that's correct. Sorry. So asymmetry is one of the cardinal features of idiopathic Parkinson's disease, and that is your part 1 MRCP questions. All right. So in the clinical case, we always ask whether you have this runs in the family, and let me just move this one this side. And clinically, you try to see whether the propranolol improves this or not. And when there is a confusion, suppose the patient is having, like olanzapine and other things, which can actually cause some tremor, then you do a DAT scan. DAT scan will be negative in those conditions. Happy with that? Right. So now this is a bit long, but it's clear cut. This is 76-year-old female presented with recurrent falls for the last 1 year, and she was falling backwards. She has become clumsy and her voice was become feeble, hypophonic. So when she is talking, the voice is slightly hypophonic, not able to produce that amount of loudness. She was generally rigid with bradykinesia. Okay, there was no tremor. There was no postural drop in her blood pressure, but there was restricted movement of the eyes. So what do you think? What is the diagnosis? Progressive supranuclear palsy, multisystem atrophy, Alzheimer's, idiopathic Parkinson's disease, Huntington's. Excellent. All of you got it. Absolutely. I'm delighted. Thank you so much. Okay, so this is the very important thing that you need to be able to understand, that these patients will rigidity, truncal rigidity is the most important thing, and they will be stiff, and eye movement is the most important thing. And based on the eye movement, you will see that they will start to have fall, because they can't, especially when they are coming down, they can't see their stairs, and when they are sleeping, the head is bent back because they can't see down. So that is called digging in the pillow sign. So these are the important things you can pick up. Okay, so now this is that was just to kickstart the whole thing. Now coming to the presentation. So 78-year-old male admitted with fall without loss of consciousness. Okay, so whenever there is a history of fall, you always need to ask whether the patient lost consciousness or not, because it has actually two paths that you need to take. He had ischemic heart disease for the last 10 years, atrial fibrillation for 5 years, diabetes for the last 20 years. And these all have importance, so remember those durations as well. And he was on apixaban, isosorbide mononitrate, ramipril, dapagliflozin, bisoprolol. Wife felt that he has become slightly clumsy, he had few tumbles, he is slowing down. And when you examine the tremors in the hand were there, he was slightly stiff and stooped. What do you think is happening? What are the issues that we need to be addressing? Quickly. So he's slowing down, isn't it? I mean, he's slowing down, he has got tremors. So we are thinking about Parkinson's disease, isn't it? So this talk, I'll just give an overview of Parkinson's. And then this patient is falling, isn't it? So you really need to think about whether we need to really exclude postural hypotension. He can fall from the Parkinson's disease. Parkinson's disease itself can cause postural drop, but you have diabetes mellitus. It can cause all the autonomic neuropathy where control is poor. They can fall. He's 78 years of age. There can be of senescence in the autonomic system. In spite of anything, they can have postural drop. So that is high agenda. Okay, so let's move to the next bit. So as I talk about the Parkinson's, are you aware who diagnosed or who described the Parkinson's disease? So this is James Parkinson's from Shoreditch, London. So he was a physician, very astute physician, and he had 3 patients of Parkinson's disease, which he followed them through, and he observed 3 other patients on the street, and then he published uh, a, uh, a book. It's not, I mean, I have got a copy of that book in my office, which is just 66 pages, and he put it as shaking palsy. He was thinking of paralysis agitans. The name and the way he has described it is almost in, it captures everything, all the features that we see today. Is a brilliant work. And the name Parkinson's disease was given by Charcot about nearly 60 years after his death, or after he presented the thing. And that's the book I was talking to you about. So what is Parkinson's disease? As you can see, is a neurodegenerative condition. It's the second most common after Alzheimer's disease. Male to female is slightly male preponderance. It's a global presence, but more common in East Asia, mainly China. And we do not know still what is causing that. Different hypotheses are there why the dopaminergic cells are degenerating. There is some suggestion that this could be genetic, this could be familial, this could be due to environmental factors, but we do not know exactly what is happening. So as I mentioned to you, that cardinal features are resting tremor. Now, what does 4 to 7 hertz per second pill rolling means? So it's an oscilloscopic, okay? So it's 3 dimension, it's moving in 3 directions, and the speed is quite fast, 4 to 7 in per second. But if you look at essential tremor can be faster. It's much faster, is 4 to 12. But Parkinson's is about 4 to 7, but still fast. And there is a movement as if you're pill rolling. It can affect head, trunk, jaw, chin, tongue, and lips. When it affects the tongue, patient's family or wife will say that he sometimes struggle with speaking. When the lips, you can see the lips is trembling, and when he is eating or drinking, he starts to have some problem drooling, not the normal drool that you see. With Parkinson's, we are talking about initial presentation with the lip involvement. Jaw, chin involvement, the wife or the family will say that there is something wrong with his chin, is moving all the time, and turns out to be Parkinson's disease. Rigidity, a stiffness, and that is stiffness in equal and opposite muscles, like a lead pipe thing. And when there is tremor interspersed with the rigidity, it's called cogwheeling. Okay, so always remember that it is different from spasticity, because spasticity is clasp knife. So when you try to open it, it doesn't open and then suddenly opens, and then when you try to close it, doesn't close, suddenly closes. So that's clasp knife, but that is for pyramidal tract. Parkinson's is extra pyramidal, where you have got lead pipe continuous thing, continuous like a lead pipe. And when you're in the clinic, when you ask for bradykinesia, you ask the patient to make a open close, faster, faster, but you will see that one side becomes slow, and that is one of the things that you can do test. Postural changes, you can say the patient will have festinated gait, poor arm swing, and you can make out, you have all seen the Parkinson's. Now, non-motor symptoms of Parkinson's are more troublesome to the patient, and what I have divided that into cognitive, autonomic, and sensory. Okay, so I'm going to describe on the cognitive, autonomic, and sensory one by one. So if you like the cognitive, it can cause anxiety, depression, dementia, fatigue. It's very common to say, but you start to have very open eyes, especially older people who are coming. They say unusually they are getting fatigue. Hallucinations can be presentation. Sleep disturbances can be presentation. Autonomic, excessive sweating, shortness of breath because all the chest muscles are stiff, they can't breathe. So that is again a presentation. Orthostatic hypotension, as I mentioned to you, constipation, sexual function involvement, urinary problems, nocturia, and suddenly rushing to the toilet like overactive bladder syndrome, drooling. Now, this is important. I think you should be careful about this, because these sometimes I have seen people have been dismissive, or they are not very careful. They start to get tingling sensation in the fingers. You start to think, oh, this could be just neuropathy and other things. You checked for it, but things are coming back as normal. But these are all presentation of Parkinson. It's not very common, but you can get that. Sensory problem or olfactory problem, anosmia, diffuse pain all over body, and urge to move all the time, akathisia. So all the time, and sometimes internal motion inside the tremor is, you can feel, it's not mentioned there, but they can still have tremor inside. So far all okay. So let's move on. Now I just want to tell you about the Parkinson's disease. So basic thing is there is a lack of dopamine, and dopamine is, it can cause nausea, vomiting, so we can't give it. So it has to be given with, the levodopa is given with benserazide or carbidopa. You can see there are two combinations, madopar and sanamet. There are two combinations that you can give, so that it prevents the peripheral change of stops the levodopa changing to dopamine. That helps that more amount of levodopa can enter the blood brain barrier. Now important thing is, benserazide and carbidopa doesn't cross the blood brain barrier, so they are outside working. And the same with COMT inhibitor, tolcapone and entacapone. They reduce the peripheral conversion of levodopa to dopamine, so more amount of levodopa can enter the brain, and where they can deliver the dopamine which is deficient in this patient. And then you have, one is levodopa, the second is dopamine receptor agonist, which are I'll probably as describe in the next slide, MOG-B inhibitors, COMT inhibitors, and this one. This one I have taken from Kumar and Clark, and it is beautiful picturization. Can you see, this is the blood vessel where you have got levodopa and COMT, and this is your dopamine, and you're trying to prevent the conversion by blocking the AAD and COMT, and it enters the nigrostriatal neuron in the brain. This is the blood-brain barrier, and this is striatal. So it works, it converts, gets converted here. Dopamine is more there. You have got MAO inhibitors, MAO-B, which allows more release of dopamine, and then you have amantadine, which pushes the dopamine from the nerve terminals, and dopamine agonists behave as if they are dopamine. They are not actually dopamine, but they behave as if they are dopamine. So you can see they are working here. Okay. This is another description from the same, not much. Same thing is there. So the Parkinson's PD-Med early trials suggested that you can use levodopa dopamine agonist or MAO-B inhibitors, and their advantages, disadvantages. But overall, what we now the whole school of thoughts keep on changing. Initially, we used to say delay the dopamine if the patient is not symptomatic, try to avoid it. Then there was suggestion that the early you give, the better it is. Then there was a move towards starting dopamine agonist initially. Then so the thoughts keeps on changing. What I normally do, I normally start with levodopa. I start with the 50 milligram dose, small dose, and then titrate it. And when I have given about 100 milligram five times a day, mid morning and mid afternoon, and again, if I am giving some Madopar dispersible in the morning for the patient to start working, then I think when and CR in the night, when then I actually add extra tablets, which is called adjuvant therapy. Then I can either use dopamine agonist or MAO-B inhibitors, but this is generally the approach. Generally, I take it. Dopamine agonist is divided into two parts, non-ergots and ergots. I think probably I just want to, you can see the names of them, but the important bit is that when you, so non-ergot, we try to avoid it because of the complications that it has. It causes pericardial peritoneal effusions, fibrosis, cardiac valvulopathy, and when generally and these are coming from a fungus, and non-ergot are the synthetic. So they are not coming from, but they are synthetic, but they behave like ergot. So they are called non-ergot agonist, which are pramipexole, ropenolol, rotigotine, which we routinely use. But you need to be careful as FY2 doctors, because you will be doing clinics, and when you proceed to IMT, impulse control disorders is one of the main things that you need to be very careful. These patients can have pathological gambling, hypersexuality, punding, and hyperphagia. Punding is when there is a compulsive desire to rearrange the things without any purpose, and hyperphagia when they start to eat a lot, and in fact patients put on weight. My advice will be that you write it down that you have described about the side effect, document it, and each time whenever you see the patient, discuss about these things, because we had trouble in the past as well. Now, when you keep on adding these medications, the problem is that means the disease is progressing, and this is called rational polypharmacy, because one thing we say that you need to keep on stopping medication, but here you have to keep on adding medication. So, but you can justify by saying rational polypharmacy. The role of other therapists, always physiotherapist, occupational therapist, and speech and language therapist. Speech and language therapists are also helpful. Sometimes we don't use them much, but they help with the communications, how to speak loud, about the drooling and other things. So involve them early. Parkinson's nurse specialists are important adjunct PDSN, what we say, Parkinson's disease nurse specialist. they do clinical monitoring of the patient, because the it is for a clinician to manage all Parkinson's medication becomes very difficult. We give overarching things, and the final management is done by the Parkinson's specialist. They can do medication adjustment, and there is a continuous point of contact for them. And they can also help with the support things, and these are all available: statutory sick pay, employment and support allowance, personal independence allowance, attendance allowance, carers allowance. And they can introduce you to Parkinson's UK, which is a very good organization that helps a lot. Lots of valuable informations are present there. If you get time, you can have a look on that as well. I will suggest that avoid abrupt withdrawal of levodopa, as it can cause Parkinson's hyperpyrexia syndrome. This is a new name for neuroleptic malignant syndrome. Suddenly you find the patient's temperature has gone up, patient has become very stiff, patient is completely confused, and this is due to the dopamine transmission. This is an emergency, and the way you can check it: check the temperature, CK will be raised. Clinically, we check the bloods including CK and full blood count. White count also goes up. This is an emergency. Get the neurologist involved, get the medical team involved, because if you don't do things, the things can just deteriorate. They will end up in renal failure and other problems. Now, so that was the overview. Now the second part is the patient is coming with fall, and the nurse comes to you and says that the lying blood pressure was 160 by 90, and the standing was for 3 minutes was 105 by 60, and he was dizzy. So what do you think? What is happening? Any shouts? Anyone can write down there? Yeah, you agree this is a postural drop, isn't it? Can anyone tell me the what is postural drop by definition? What is the definition? So systolic more than 20? Yes, that's correct, correct. And you need to symptomatic, correct, but less than 90. If a systolic blood pressure drops less than 90, that is also considered as postural drop. Okay. And when you're doing it, you need to look at the pulse as well, whether there is compensatory tachycardia or not. Sometimes there is autonomic failure, then that may not happen. But in clinical practice, we also want to make sure that we have, because this patient has diabetes, so you need to, and for 20 years, so chances that this patient also have diabetic neuropathy, diabetic autonomic neuropathy, that will be contributing to this. Always check for excess alcohol. In clinical take, we are not taking the history generally, uh, and so we need to take a history of alcohol. Whenever they say that a small drop, you need to ask them to elaborate. Vitamin deficiency, especially B12 and folate deficiency, they can also cause autonomic neuropathy. Previous exposure to chemotherapeutic agents. Any chemotherapy agent that comes to your mind? Anyone who can shout or write? Anyone? So I think one is your vinca alkaloids, okay, and then vincristine especially can cause neuropathy, cause problem. And of course Addison's disease, you need to think that, I mean, these patients can still have Addison's disease. So how do you manage this? So the first thing is managing postural hypotension is by non-pharmacological methods, and then pharmacological methods. So first, medication optimization. If you feel that some of the medication can be stopped or decreased, you can do that. Second is optimization of timing of the medication, whether you need to give the blood pressure tablet at the bedtime. That probably may be useful if it is once a day tablet. If someone is on alpha blockers like doxazosine, whether you can stop that and change to something else. Those type of things you need to look at. I normally ask them, if it is confirmed and the patient is symptomatic with postural hypertension, that you keep glass of water, about 300 mils, first thing in the morning, and drink it first before you mobilize, making sure there is you have got somewhere to hold on to, and then mobilize. We used to give compression stocking in the form of TED stocking that was available, grade 2, class 2, but we didn't find much information. Now we have changed our practice to full length compression stockings. So it comes like jeans up to the groin level, and it is very helpful and useful. So TED stockings is, what is the full form of TED? Quickly, just to keep you alert and awake. Anyone can do that. So it's called thromboembolic deterrent. Okay. So thromboembolic deterrent. So anyway, and then what I will suggest, when they are sleeping, then should have a little pillow, not too many pillows, because if you have 10 to 20 to 30 degree raised head, that helps in the atrial natriuretic peptide, which preserves the sodium. It doesn't allow it to uh, diurese much. So you basically you are trying to retain the fluid there. The second thing, and the contraindications you need to be remembered whenever you are suggesting that, feel for the patient. If the patient has any peripheral neuropathy signs, or sorry, any peripheral vascular disease, so arterial pulses are not palpable, then you wouldn't give that. If the skin is not right, if there is ulcers, so check all those things. Fluorocortisone we normally use. It is again, it works by fluid retention, but you need to understand that if you are increasing the weight of the patient by say 250 or half kilogram, it will affect the rehabilitations. This is not I prefer generally. I normally prefer midodrine, but the subtle effect that the patient will have itching in the scalp because of the piloerection. So if in the patient is in the ward, if they start to itch, you understand that this could be the side effect of midodrine, and you don't have to stop it, just reduce the dose and it works very well. And when you have the second line treatment like atoxametin or paroxystigmine can be used, but I think probably from your point of view, I think it will be useful to get a specialist opinion how to manage that. But you also need to understand that sometimes, in spite of all the treatment, pharmacological, non-pharmacological, you're not able to make much difference to it. Then you have to accept and have a discussion with family that the wheelchair is the best way to move forward, and you need to accept that. Of course, it's a shared decision, but you need to involve the family, otherwise a patient will be falling. But when you're talking about these things, you also always want to make sure there is not supine hypertension. There is another thing called systemic hypertension and orthostatic hypertension, SHOH. You need to be aware this, especially if you have Parkinson's plus syndrome, which is multisystem atrophy. You need to be careful with that. Now, so I think you all agree that you need to avoid large meals and excess alcohol, excess heat. This is self-explanatory. And there are some of the maneuvers that you can do, like fist clenching. The all these things you can have a look, but the most common what I have noticed from my Parkinson's patient, they know that is postural hypotension is happening. They start to move their legs. They will ask for water, allow them that as soon as they feel a bit thirsty, ask them to give water, and they will start to tap their legs, ask them to encourage them, because it is slightly socially uncomfortable, but they start to move the legs. That is the only thing that I have seen it works. It helps. So but other things are there as well. Mm. So thank you very much. I hope I'm in time.